Okay, so my name's Erin. I'm presenting today on a harm reduction emergency response program in BC. Thank you, Mayor, for providing the land acknowledgement today for the space that we are presenting in. I also live in Victoria, and I completed my practicum here, and I offer my gratitude to the local nations, the Lekwungen and Wasanik nations, for their care and teachings on this land. My practicum was also guided by the Coast Salish teachings that were gifted to the Provincial Health Authority. So I'm going to talk about my practicum, the project I worked on, then take a step back and talk more broadly about the intersection of evidence and policy, and as it relates to harm reduction work. So I did my practicum with Health Emergency Management BC. They are a department of the Provincial Health Authority in BC, and they provide healthcare emergency management leadership and support to all of the regional health authorities and to the Ministry of BC. I was specifically working with the provincial operations team, and they coordinate provincial response structures, support multi-jurisdictional alignment during emergencies, and they also deploy emergency medical equipment, supplies, and temporary facilities, which was the area that I was working in. So for my practicum, I was working on a harm reduction program with HEMBC. The program is HEMBC's Overdose Prevention Equipment Deployable Alternative Care Site. It's a very long name, but what it is it's emergency harm reduction units that can be deployed throughout the province during an acute emergency or an evacuation to provide harm reduction supplies and infrastructure during supply chain disruptions, increased demand, and evacuations. So the program has 3 different modules. The first module can be requested by a community when they just need that physical harm reduction supply, so things like safer inhalation supplies, and they already have a space set up to distribute the supplies so that it can be sent out for them. If a community doesn't have the infrastructure to actually distribute the supplies, then they can request Module 2, which provides the actual infrastructure for a temporary harm reduction site. And then Module 3 provides all of that same equipment and infrastructure from the first 2 modules, and it also provides all of the equipment, supplies, and infrastructure for a fully operational temporary overdose prevention site. The program is set up to be deployed with the help of HEMBC, but it's really set up in a way where HEMBC provides the materials, they provide the asset, and then the community utilizes it in the way that best serves their community. So the context for this program, this was discussed already yesterday by our keynote speaker, Catherine, but BC is still in the ongoing toxic drug crisis, and alongside the toxic drug crisis, BC is experiencing increased climate-related emergencies, which we also heard about yesterday in Em's presentation, especially with floods and wildfires, which results in dual emergencies. And this quote here on the slide provides a really good summary of the work I was doing and why it mattered. The climate emergency is a global crisis causing irreparable harm to people, communities, and the planet. We can only mitigate and adapt to its impacts. Acute impacts require rapid and emergency responses, but both acute and long-term impacts require foresight and policy planning. Our emergency harm reduction program provides this acute response during an emergency, but my practicum also looked at how drug policy supports and inhibits harm reduction services in BC. So looking more at the context, risk during dual emergencies is compounded for people who use drugs for several reasons beyond the disproportionate impact of the toxic drug crisis. The social environmental context for people who use drugs often means that they live in more hazardous areas and areas that are more likely to need evacuations, which increases their hazard risk. People who use drugs often have less access to protective resources as well, and this includes things like stable housing, income, access to emergency information, ability to stockpile medication, and access to substance use services and safe transportation. And these risks are further compounded during an emergency by increased discrimination, increased surveillance, changing drug markets, and deprioritization of harm reduction and healthcare services. So all of these factors, which are largely created by colonial systems in BC, are really what cause a natural hazard to become a natural disaster. So with HEMBC, I had the overall goal of ensuring that the program was ready for deployment this hazard season, and I did this through 2 objectives. The first was a pre-implementation assessment that analyzed the program's ability to advance health equity in an emergency context. And then I also worked on all of the inventory for the program, ensuring that we had a strong evidence base for what was included in the program. And then I also reviewed all of the internal and external documents for MBC and ensured that the regional teams were aware of our program and ready to request it should it be needed. So through these two objectives, I came to several findings, and that's what's going to inform my conclusions on the next couple of slides. So my first finding was that the program aligns with community needs and needs identified in the literature during emergencies, during climate-related disasters. We also found that our program is filling a gap where there previously haven't been harm reduction services during acute emergencies. And I also found through just my various discussions with folks during my practicum that we were meeting community needs for our communities in BC. When I thought about my findings as a wheel, this evidence forms the hub of the wheel, which is very strong at its core. But in order for us to actually advance towards health equity, we need our spokes to be strong as well. So that brings us to my second slide, which is the spokes. This includes emergency governance, regulation and drug policy, political support, organizational support, and regional prioritization of harm reduction services. So I'm just going to talk about a few of these areas that are particularly important for harm reduction services. Emergency systems continue to reproduce and reflect existing inequities in BC, and they often fail to recognize social determinants that affect people's access to emergency resources and preparation, which Em already talked about in depth yesterday. Drug policy in Canada also constrains harm reduction services. Right now, the federal government grants exemptions for drug possession, but it's a very lengthy process, and it's not something that is easily accessible, especially for mobile or emergency responses. And that's particularly important for First Nation communities. They're disproportionately affected by emergency evacuations and by the toxic drug crisis. And because reserve land is viewed as federal land, the federal drug exemption process creates barriers for harm reduction services. And then political and regional and community support also varies. For example, the BC government, the NDP government, endorsed decriminalization of drug possession back in 2023. And now, as we all know, in February of this year, they have ended that decriminalization, which has increased surveillance and decreased accessibility of harm reduction services. So overall, the program is strong at its core, but a lot of the spokes around it are still weak, and that's affecting our ability to advance towards health equity, especially in an emergency context. So this left me with three broad public health implications. The first is that health equity needs to be operationalized beyond value statements. Health systems in BC already prepare for emergencies through processes like stockpiling, but harm reduction services haven't been something that has been widely considered in these processes. Second is that emergency management is a public health concern. Emergencies don't create inequities from nowhere. They're amplifying inequities in areas where we have already fallen short. And excluding harm reduction is not a neutral stance. It's actively reproducing inequity. And my last finding was that evidence alone does not drive implementation. Like I said, we have a strong evidence base for harm reduction, and we know that emergencies increase risk, but what's determining if services are implemented is often systemic barriers and institutional support. This last implication was particularly important for me. I went into my Master's of Public Health thinking that I wanted to gain the skills to contribute to that evidence base, but I'm leaving now, shifting my personal priorities into translating evidence into practice, and especially as that relates to drug policy and the drug policy landscape. Okay, so that's all for me today. Thank you all for listening, and thank you to my MBC team.